Today we have with us Dr. Prakash Deedwania, who is a professor of clinical medicine in UCSF. We have Dr. Rajiv Gupta, who is a professor cardiology, Gandhi Medical College, Bhopal, and consultant cardiologist, Hamida Hospital at Bhopal. We also have with us Dr. Samutira Ray, who is a professor at Vivekananda Institute of Medical Sciences and a vice president of CSI. I welcome each and every one of you, sir, on our channel. Sir, today we would be discussing on lipids or dyslipidemia. So let's start with what is dyslipidemia and how big is the problem statement in India? If you can just give us the intro, sir.
Well, I think the problem of dyslipidemia in India is immense. First of all, I must clarify that in India, although LDL cholesterol may not be high, whatever LDL is there is highly atherogenic, so-called small dense LDL in the setting of obesity, diabetes, pre-diabetes, etc. We have shown in the India Heart Watch study, there was a large epidemiologic study of nearly 6,000 plus patients, that even in younger people, people who are under 25 years of age, there was a high preponderance of dyslipidemia. I think the most important point that I want to make is, regardless of what sort of dyslipidemia people have, the treatments are available. There are widely available agents now. In India, very fortunate that we have statins that are extremely inexpensive, and today there is no excuse that we should not be using these drugs when they are appropriate to be used.
Thank you, sir. Sir, lately the European Society of Cardiology released a 2019 guidelines on dyslipidemia, and a new addition was done in terms of recommendation for ezetimibe. So, Dr. Ray, sir, can we have your insights as to what and how ezetimibe came into the picture, and why was it not there before?
Ezetimibe was there in a clinical practice for more than 30 years. Initially there was some enthusiasm, but various meta-analysis showed side effects of ezetimibe, including cancer and liver toxicity and muscle toxicity. So they were not popular and their role was always doubted. But then came the IMPROVE trial, which showed on top of simvastatin, though it was a wrong choice by today's standards, of up to 40 milligram in secondary prevention trial, which is obsolete nowadays. You cannot use simvastatin 40 in secondary prevention setup. It is not recommended. Addition of ezetimibe causes some around 18% further reduction of LDL cholesterol. But on sub-analysis, it showed that only in the diabetic population, it translated into clinical benefit. In the non-diabetic segment, it did not have any impact, either it is stroke or MI or cardiovascular death. So I would say it is a cheap drug. So always welcome in Indian scenario when your target LDL is not achieved with the highest tolerated dose of statin. So in a cool situation, you can always add ezetimibe and wait for 6 weeks to 3 months to see whether you are achieving the LDL goal. But I won't recommend to waste your time on it if the situation is hot, a young premature coronary atherosclerotic disease, having acute coronary syndrome recurrently, to waste another 3 months time depending on ezetimibe.
Yeah, I would agree. I think the statins are the first line therapy. Right. Most of the time they don't cause any significant effects. We have shown in the large trial, TNT trial, in 10,000 some odd patients, that there was no significant liver damage, there was not even a significant amount of myalgia or rhabdomyolysis. Yes, myalgia does occur in about 5 to 7% of the patients, and actually with my good friend Peter Sevier in ESCOT trial, they have shown that this myalgia is more of the nocebo effect, because what they did in the trial is they took the patients who were on atorvastatin and then switched them to placebo. And they didn't tell them that they're switching them on. They still had those people who had previously placebo, right, they are giving atorvastatin, they had no problem, and the people who were on atorvastatin, they were giving placebo, they still said they have muscle effect. So I think nocebo effect is what we call perception. And I think so that is the main thing, and this is one of the main reasons why many patients say they can't tolerate it, this really myalgia is insignificant problem. It occurs in 5 to 7% of the patient in real life. Usually tolerable, and one can really get rid of it by switching statins from one statin to another, because we don't understand the full mechanism of it, but switching statins sometimes can be very helpful. So I agree with Samutira in the sense that in high-risk patients, you should not waste time with ezetimibe. It's a good drug to add to a statin, but it's not a good drug to be used individually or exceptionally just by itself.
And also understanding the importance of production of cholesterol. It's not only the intestinal absorption, but the hepatic production and the production in the muscles, which equally contributes to the bad cholesterol. So unless you tackle and attack all the three mechanisms, one may not be sufficient.
Thank you, sir. Also, sir, as we know that Indians specifically have a high carb diet, which has already been documented in multiple evidences, which says that 60% of our diet at least is carbohydrates. And I'm sure this is the main reason for obesity to come into the picture, and having a serious problem now, going towards diabetes, going towards cardio and other comorbidities around it. So how is Indian dyslipidemia different from the rest?
To briefly tell you that Indian dyslipidemia is predominantly vegetarian, and they consume more of trans fat rather than cis fat.
Okay.
And this accounts for a higher LDL cholesterol, but more importantly, as Professor Deedwania told us, it is the small dense LDL cholesterol, and this cholesterol would penetrate into the arterial lumen, and homocysteine contributes equally by causing this LDL to become an oxidized LDL. So the triglycerides, the small dense LDL, and also the lipoprotein A contributes to the thrombogenic component more than the atherogenic and the antifibrinolytic nature of lipoprotein A.
Well, but going back to your question, you said, how come this 60% carbohydrate ingestion is causing the epidemic? That's because nowadays we are using refined carbohydrate. If we go to what our forefathers ate in India, such the rough grain, the actual grain like the corn, bajra, millet seeds and other things, then you don't have that problem. It has been proven by comparison of various carbohydrate diets in Western literature that if you have a whole grain diet, and I also want to emphasize that our vegetarian diet is pseudo-vegetarian diet. Even though it's vegetarian, we eat so much fried food, samosas, this and that, and paneer, etc., which are very high in fat. So our vegetarian diet is not true vegetarian diet. But what I would say is the answer to this problem is if we use complex carbohydrates and use vegetables, particularly the cross vegetable like cauliflower, cabbage, broccoli, etc., then one won't have as much of a problem, if you will, in terms of obesity, diabetes, etc. Because yes, simple carbohydrate increase or make a person insulin resistant, and that starts the whole kind of problem with atherogenic dyslipidemia, diabetes, metabolic syndrome, and so on.
How important is this message? Because this increasing fibers in the diet would reduce your intestinal absorption and also reduce the associated non-conventional risk factors like the fibrinogen and other risk factors. Very important.
Yes, absolutely.
What we call that Indian dyslipidemia is actually a misnomer, where you see the high TG and low HDL, and you take our focus off LDL, as if LDL is not important for Indians. But as we have already explained, my colleagues over here, that it is a small dense LDL ultimately which matters. With this bad association of low HDL and high TG, what happens, whatever your LDL is becomes small dense, and that becomes atherogenic. Ultimately the target damager is the LDL, small dense LDL, as we cannot routinely measure it. So we are not getting focused onto you. And the carbohydrate, if anything, increases the TG level, the triglyceride level, which makes you the metabolic kind of dyslipidemia, which actually going to do the small dense LDL level. So ultimately carbohydrate is bad as much as your lipidology is concerned as well.
Well, I think the important message between what we are, three of us are saying is that clearly dyslipidemia in Indian subjects, except for those who have familial problem, is mostly environmental induced. It's the habits of the people, and you can really control it. And now, unfortunately, when I see the Indian young generation, hardly anybody is eating typical Indian diet. They're all eating pizzas and all these different, very, very saturated, processed, fine carbohydrate diets, which are highly diabetogenic and also atherosclerotic diet. So one can change these habits and one can really make a significant impact in that.
How important is this message of lifestyle? That unless you interplay with the genetics, you can have a loaded gun, but the environmental would play the trigger, and if you have lifestyle control, probably you are doing all good for your patient.
Absolutely.
And whatever trans fatty acid you are taking, whatever, you are frying it. So everything is lost. So even if you may be feeling assured that I'm taking trans, but when you are cooking it, everything is gone. So by default, you are taking the bad oil anyway.
So for example, Samutira, I see a lot of people in India, they're telling me, well, I'm using olive oil, but once you reach a certain saturation point, olive oil also turns into trans fat.
Absolutely.
So I think the way we cook is also very different.
The process is very important.
Reheating also becomes bad. A good oil by reheating can become into a trans oil, and that is converting an polyunsaturated or a monounsaturated oil into a completely saturated fat.
Great.
The other message is the higher use, particularly in south, of palm oil, coconut oil. That's all saturated fat, particularly fried. So I think one has to be very concerned about it, and this, in my opinion, explains some of the very high risk of coronary artery disease, atherosclerosis in Kerala and other places. Even though they are thin, even though they don't consume that much direct fat, but they are consuming this palm oil and saturated coconut oil, and this is purely because of the cost. Palm oil is the cheapest oil they can get.
True, sir. And so I understand, sir. But what I would look in for right now is I would go.
You are accomplished with. Heavy exercises are not required. Exercises would reduce your heat shock proteins, and this would take care of stressful situations. Meditation would change the alpha and the beta wave complex in the brain and avoid sudden events. Yoga would
follow it. He or she is not going to follow it. So keep it simple. Keep the message simple. Have one intervention at a time. Maybe if he's not doing exercise, that may be the first thing to.
As recommended in Western guidelines. Because as Dr. Deedwania just said, we have so many young heart attacks, 25, 30, 35. So I think whenever you encounter a person, being an accompanying person, be a caregiver of the patient,
they have 30% greater risk of having a stroke. Everybody became compliant. So I think a message to be delivered that hits home, and it's very, very important. And I think the other thing one can use, although I don't recommend on a routine basis, is if they are not convinced, which many executives and educated people will not be convinced easily, is to do a simple test we call CT angiogram. And by doing that test, as long as one does it with a specific purpose, it's fine. So what it does is it identifies any early stage atherosclerosis in the arteries, and showing a picture, as they say, picture is worth 1,000 words. Say, okay, look here, you don't have the problem, but it has begun, and it's going to kill you, or it's going to give you a heart attack and all that. That will really convince them to change their, because lifestyle change is the most difficult thing. Even I can tell for myself, and probably all of us can agree, he doesn't need to do it because he's in good shape. But I think we all can use some lifestyle change. It's the most difficult thing to do. So I think if we convince them with some data and educate them, and these tools are available. For example, in the American College of Cardiology website, there is a tool available that looks at the risk factor, and there is then one can modify those risk factors and the score, and then show how much your risk is reduced. That kind of education is needed to convince particularly people who have not had disease yet.
So arteries are all one, be it the carotids, be it the peripheral vessels or the coronary vessels. We have done some studies on the carotid intima media thickness to correlate with the rising lipid level, and as my co-speaker said, that look for the other vessels and try to intervene as early as possible.
Very relevant, because sometimes I have seen.
No, I think that's a very important message. I mean, to me, we have been emphasizing endothelial dysfunction for 20 years.